I had to say that whenever we try to remove any lesions, we give an incision, and the collateral outcome of that incision would always be a scar. So we as plastic surgeons, we try our best to hide these scars by putting incisions on the crease lines. But in case of stilt, what we are going to do is we are going to place these incisions very, very far away from the side of the lesions, and just to make sure that no visible evidence of the surgical procedure remains at the side of the lesion. So everybody knows that whenever we do any minimally invasive surgery, conventionally starting with lap chole, we started with 4 pots. Some tried with 3 pots just to reduce the number of scars. Then even people are trying with 2 pots, and sometimes we even embark on doing single incision laparoscopic surgery. And to the extent of few anecdotal reports of having done natural orifice endoluminal surgeries, that's called NOTES. I wish to know from the audience today that if I have to remove my gallbladder, and if somebody proposes me to put through any other orifices to remove my gallbladder, that would be a bit illogical. So that's the reason why SILS and other few pot surgeries are not very, conducive for the particular procedure, just because of the safety concerns. So the literal meaning of stilt is doing something where we are doing something in a very concealed manner, as we have seen in all those stilt vessels or stilt aircraft, as we all do. So again, when we are talking about minimal access surgery, we are more concerned about the saying goes that there's less hospital stay or less cost, or there's early recovery. Those are all remediable, but we are never taught, or we never explain to the patients that whatever scar we put on that particular patient will remain there for the rest of their life. Imagine these ladies, if we have to do any surgical procedure on the face, neck, and the upper chest. Sometimes it's worthy to do, but we cannot guarantee that there won't be any scars. So if for the particular patient, if they have these scars, how would it be? And the self-esteem of all these patients, you would very much can think about. Just see our dear Angela Jolie, if she has to undergo still or conventional surgery in the neck, she would rather have to live or act in the future with these full covered garments. So especially for ladies, face and neck and upper torso, that's a concern. We can not offer to give any scars. So as I said before, stilt surgery is nothing but replacing the long visible scars for any conventional surgery with a smaller incisions placed somewhere hidden in the body parts. My declarations: I'm not this guy, new laparoscopic surgeon, but we always are concerned with the saying that first do no harm. So indications for stilt surgery, we have benign tumors of the face, especially on the forehead, like angular dermoids, any lesions of the neck and chest wall. And for us, we do maximum in all torticollis cases, and few breast lesions, and I'm not mentioning about smaller extremity benign tumors. So what are the gadgets required for this procedure? Nothing. We need just a standard laparoscopic setup. Apart from that, we have specific instrumentations we adapted just for this technique. We have, if you can see, we have triple lumen trocar that was made by us, a suction device, energy source like either monopolar diatomy or ligature or harmony, whatever you have, balloon dissector in the form of Foley's catheter, and a modified curved fan retractor. As you can see, conventional surgery instruments. And the inspiration which I got was when, way back in 2014, when we had first organized the robotic conference in one of the hospitals where I work in Guwahati. We invited one surgeon from Italy, and she uses something like a lift instrument. But I was intrigued by the size of the incision which she put to remove a thyroid nodule. So we had many problems when we started doing stilt surgery. One is the space constraint, because we are working not in a cavity, but in a self-made cavern. Second is, since we don't need any triangulations, which is the principle of cavity surgery in minimally invasive surgery, so we adapted. And the constant air leak and the post-operative sequelae having to face subcutaneous emphysema. Then whether to use 0 degree or 30 degree, because certain process needs 0 degree and certain process needs 30 degree. So we were a bit in a dilemma. And in fact, when we go through the literatures, and there were none. So that reminds me of a saying by Robert Gross, the father of pediatric surgery. He said that if an operation is difficult, you are not doing it properly, right? So we started modifying our own instruments. We started with this double barrel. We spent time shouldering each other, burning many trocars. Ultimately, we came through, we call it a breakthrough, and we finally could make a single two double barrel trocar. Then with that, again, we faced lots of problems with smoking and difficulty in evacuating, and that consumes lots of time. So we added another tube. So ultimately, we were very much satisfied with having this triple barrel trocar. So with this, we managed to insert one small chapter about the still surgery in one of the textbook of pediatric surgery. So we had many problems. Apart from the problem which I had cited before, there were no standardized instruments for this procedure. And as I said before, the operative field was full of smoke, and that results in poor visibility. We were just thinking how to avoid all this. Then we thought, why not we just start inventing another instrument? So this is nothing but a very, if time permits, Chairperson Sir, I'll come back. It's just only a 2 minutes video, but I would like to present at the end, or if permitted, I can present now. So this is just nothing which we can use with any conventional smartphones, or you can just connect to a laptop. Sorry. I'll come back. So in total, we did 14 cases over the past 7 years till 2021. Out of that, 11 cases were of torticollis, 1 case of cystic lymphangioma of the neck, 1 angular dermoid, and 1 solitary thyroid nodule. The basic steps: we put all the pots in inconspicuous areas. For face, we put above the hairlines, and for neck and upper chest wall, we put in the axilla. There are 3 pots which are placed in the subcutaneous planes. Initial tunneling is done without CO2 gas. And the basic step is to create a large cavern. And what I'm describing here is just for torticollis. So we can just see a brief video. This is how we did. This is about torticollis. Incision was placed in the axilla, anterior axillary fold. We create a cavern with the use of 16 French Follis catheter. The only thing which we need to remember is the camera, the monitor, and the operating surgeon all has to be in one straight line. If anybody can help me play with the newer video, it's not playing. So it's very simple. Since there are very fewer surgeons, I would like to skip because this is 2.5 minutes of video. It's a very simple procedure which we do normally in open cases. The only issue is we should take care of injuring and to avoid injury to the internal and external jugular veins, and also to the superior thyroid artery. And not to forget that these are all fibrous tissues. We do endoscopic procedures just in all those muscular torticollis cases, not for other cause of torticollis. So this is a retrospective review of 14 consecutive cases done over a period of 7 years. As I said, we had maximum 11 cases of torticollis. The outcome measures included the cosmetic scale called POSA score that was quite acceptable, and there were no cases of conversions. These are few of the cases. The lines are made by us. The vertebral line, the most important line is the mentometopic. So we were just describing this just to check in the postoperative period whether the cosmetic deformity is fully corrected or not. So we published this data way back in 2016 and 17 consecutively. So this is the girl. I'm sorry I've revealed the face because we have taken consent from the patients. So it's quite acceptable, and in 1 year follow-up, we were just checking that the mentometopic and the vertebral line should coincide with each other, and the interacromial line should bisect the first line at right angles. Similarly, we did a few cases, 2 or 3 cases in adults, but then in adult, it's a bit difficult. Even after physiotherapy, intensive physiotherapy of 1 year, lesions is not fully corrected. The reason being, but it's quite acceptable, the reason being that if you see the C-spine X-ray, you'll find the indentations in the tracheal air column somewhere in C4, C5. So that's, the damage has already been done for this particular patient during his adulthood. So remember, we need to have a C-spine X-ray in all these cases. So this lady, she was found, selling some materials out there in More. So she came over to Guwahati and we operated her. And this is the status at 3 months of age, 3 months after surgery. And she eloped away to somewhere Mandalay and lost the follow-up. So there are many unanswered questions over here. If you see the picture on the right-hand side, we're just marking, we're just trying to figure out that there is definitely, yes, facial asymmetry. We call it facial hemihypoplasia. These changes once occurred, it's non-rectifiable. So that's what we say, that it's difficult to correct 100% in adults. And if you see the unoperated side, there's quite prominence of SM. So we were just thinking whether to go ahead with doing the opposite side, but no, with physiotherapy, this resolves in almost all the cases in our series. And literature even cites using botulinum toxins also, where we haven't tried. Again, another baby from Myanmar, the same thing. Then this again, another one. So why I'm showing this is just because that if we do this surgery in early life, somewhere around 5 or 6 years of age, then the cosmetic outcome is excellent. So this is one case where we had to report having burn. So the reason why we invented this particular instrument is just because that it doesn't cause smoking. And you don't have to remove the scopes again and again just because of that. Second, it gives a warm touch at the tip of, because it's the light source is from the LED, 6 LEDs. So this has lots of advantages, not only for the pediatric surgeons, but even for the general surgeons, gynecologists, ENT surgeons, endocrine surgeons, and the many applications which they can do with this instrument. So there's one case we had done the cystic lymphangioма of the neck. Why I'm showing this is just because that the incisions were made above the hairline. So this is one, and this is the outcome at 1 year of age. This one lady, this was just done as a trial, one of the trial where we did thyroidectomy for this lady with a solitary thyroid nodule. So this is the marking on the anterior axillary fold on the right side. This is where we place the incisions. So the key for management is physiotherapy. I'm not going to discuss on this. So in the course of this procedure, we had some modifications, like bring up a triple barrel trocar, then modifying the endoscopes, and there were no intraoperative complications. And in the postoperative period, we had one case of seroma and one case of skin burn, which I have already shown. And all wounds healed with acceptable cosmetic result on follow-up. So this is carry-home message. Plus, there still is nothing, but it's a surgical procedure where we place incisions in a very far away, hidden locations using minimal access surgery technologies. And the primary advantage is it gives an excellent cosmesis, and we have very excellent patient satisfaction also. And believe me, the cornerstone of clinical innovations in pediatric surgery is nothing but it's minimally access surgery. So just 1.5 minutes of video. Can somebody help me? Okay. This is nothing, this is an instrument, we call it boroscope. This instrument is used by disaster management team in tracing human lives. Available in the market or through Amazon, but it costs only 2,000 to 2,500 rupees. This is powered by just a USB connected to either your smartphone or your laptop. As you can see, the light. But then the limitations are the size are quite big, and the light that emits from these 6 LEDs is not powerful enough to do any surgical procedures. So we had to devise making this LED, you call it camera, smaller in size, and it's quite flexible because this doesn't involve the standard rod lens system. It's just a wire. So as you can see, comparing with the standard boroscope, our instrument is a bit smaller, which can be inserted to a 5 mm trocar. The light source is powerful. It's a 3 megapixel camera using CMOS technology. As you can see, I've just connected to a USB, and you can see the powerful light source emitting from these 6 LEDs. You can just disconnect it, you can connect it, and believe me that you can do any process on the bedside using just your smartphone. See, I'm connecting to, you can get this software in Google, there are hundreds and hundreds. So once you connect it, you can see the quality of the vision. I'm not saying that this is a replacement for the powerful standard scopes, but this might be helpful in certain cases when we need it. So I think the image is quite clear. And the plus point is you can go underwater. You can go in any places where there's smoke, it doesn't affect the vision, and you can fit in your standard 5 mm trocar, as you can see. So the triple barrel trocar which I use and which I have modified, one is to fit this instrument in particular, and the second thing is it can bend anywhere. So when you are doing angular dermoid, I don't have to shift to my 30-degree to dig out the dermoid cyst. So I end these presentations with a saying from Lao Tzu. So we have taken the first step, and we wish to cover 1,000 miles in the future. Thank you so much, sir.
Thank you, Dr. Sonny Lindo, for your excellent presentation. And it was a little different from what I thought. I was limiting to varicose surgery, but you have done face, thyroid, breast, and all. It's very nice. But it needs lots of dexterity and lots of versatility, your hands and all. This is a very, what you call, it's practiced in other part of the world, but it's less. But I thought it was not done here, but I'm very happy that you are doing it. So may I request questions from the house, please. Dr. James.
Wonderful presentation, sir, Sony. Could you just explain how do you control the insufflation and the smoke evacuation using your 3-barrel trocar?
Yes. The reason why we invented this triple barrel trocar is just for nothing. Initially when we started, we were using the standard 5 mm port, and we had a difficult time maintaining the air pressure because it was constantly leaking. So that was the reason why we started inventing this instrument, where we use, if you see the trocar properly, there are 2 holes in the main hole. One is used for lifting. So lifting is, we use lifting, initially we started with that adult fan retractor, but when you focus, when you put that scope, the light shines and you don't see anything. So that's the reason why we shortened the fan retractor. We made a bit curve upwards. That solved the problem. And as I said, we don't use gas anymore because the trouble with the gas is leaking and you don't have a proper cavity there. So just lifting and just...
So the first curve thing is for lifting.
Yes.
One is for camera.
Yes,
the other
exactly.
one is for the operating.
One is for suction. where we use a normal IV, line.
Where do you insert the operating channel?
Yeah, that's from two sides, from other sides. Once we create
from the other side?
Yes.
Okay, thank you.
There's not a single port, it's a standard 3 ports.
Thank you, doctor. One more question from Sir Kala.
Suppose in the post-operative period, there is bleeding from the thyroid operative area. How will solve the problem?
So we are not operating on thyroid. The one case which we operated, that was on a trial basis, because I have an endocrine surgeon with me, and he wanted to try something, subcutaneously. So I help him out, but we are not trained to do, because there are thousands of literatures, and the ENT people are doing it day in and day out, the thyroid surgery. But the only issue is they place the incisions in the chest wall. We place the incision in the axilla.
Congratulations, Dr. Soni, you're generating a lot of interest.
Wonderful presentation, Tamo Soni. I think it will have a lot of applications in my specialty also. There's plastic surgery. So can it be used for like breast implants, this particular technique? Because when we approach via the axilla and we dissect the pocket and throw a very minimal incision which is hidden in the axilla, I think we can place the implant and the patient.
Yes, definitely. One indications for still surgery is breast lesions, but it should not be big. It should be small enough. We haven't tried yet, but once we get the case, I think it should be more easier than neck lesions, because the anatomy which we have in breast, that doesn't involve much of the vessels and nerves, rather than those anatomy in a neck. That's a bit difficult. Breast lesion would be easier, but it should be selective.
Dr. Jugendra, please.
Yeah, congratulations, Dr. Soni. Once again, this is the second time I'm listening to you on this topic, which you presented at Nikasikon, Itanagar. And the question remains the same. Have you patented it? If not, you must do it quickly.
No, sir. In fact, we try to patent it, but the only thing is we are still in the innovative phase. We are still trying to improve ourselves. Recently, when we were just looking at the instrument to take a photograph, I noticed that the suction tube that was placed in the opposite side, so which we need to check it and we need to place it again. We need to rethink about it. So until unless we perfect this instrument, we'll have to wait to patent it.
You are having question? Dr. Samkishore, renowned cardiologist of the state.
Thank
Please.
you. Congratulations, Dr. Lindo. It was a good presentation. My question is, you had done 10 cases in 10 years. Is that
11 cases in
11 cases in almost 10 years.
7 years.
7 years.
Yeah.
And how many done in Manipur?
I think 3 from Manipur, 3 from Myanmar.
Yeah.
The rest are from Assam.
Yes.
1 from Nagaland.
Okay.
The rest are from Assam.
So it's this new technologies and expertise less utilized, I would say. So it's a question of creating awareness among the people of the northeastern states of India. Do you agree with that? I mean, we should try to create more awareness among the people that these are available, and then because the number of cases done in 7 years is less than I would have expected.
So we have started this procedure in 2013. All of us, 4 surgeons in India. One is Karan Parikh from Mumbai, one from Prakash Agarwal from Ramachandra, Chennai, Dr. Vikesh Agarwal from Jabalpur, and myself. We are at level field now. All of us are in 11, 13 cases. Nobody has done more. Mm-hmm. So we are just waiting for cases to come. But the only thing is, we don't operate in all cases of torticollis. We operate only when other form of treatment failed.
So what are the standards, the age group wise age? So these are definitely, the success rate will be high. This much is the success rate. And if the age is this in adulthood and the success rate is low, is there anything differentiation?
Our analysis suggested that for us protocol is we subject all torticollis cases. First we segregate which are the cases that we call it muscular torticollis, where there's a thickening and shortening of sternocleidomastoid muscles. So the initial cases which we get, we all subject all these cases to physiotherapy for at least 1 year. So once we cross 1 year, then I think we can operate on all these cases. But for us, the average age which we operated was somewhere around, the youngest one was around 4 years, and the eldest one was, apart from that thyroid case, somewhere around 4 to 7 years of age. And I think that's the perfect age for operating on these cases.
So younger the better, are you saying that the younger the better?
There's no standardized criteria, sir, because it's an evolving technology. We have just applied it. And we are trying to just, in fact, the last paper which we published, that was a combination of 2 centers. One is from Chennai and our center in Mother Care. So there's a total of around 26 cases. I contributed 11 cases from my side, and a few other surgeons contributed some more. So maybe in the future, we might be able to come up with some criteria for operating on cases. But as of now, I think it's too early to judge.
Thank you, Dr. Soni. We are running short of time. Already we have taken too long. Anyway, thank you, Dr. Soni.
Thank you, sir. Thank you so much.
It has been a nice session. So many, lot of interest from among the audience. And the next presentation also, I think it will be very interesting. The next speaker is Dr. Imphal. He is Associate Professor, Plastic Surgery in RIMS Imphal. He passed his plastic surgery from Tapiola National Medical College, Mumbai, and he worked for some time as a consultant at Caesar Hospital. And now he is in RIMS, and he is highly dedicated plastic surgeon. Last year also in the AMAMECON, we have seen his presentations, all those beautiful tenure surgeries. The topic of today's presentation is lower limb reconstruction. Lower limb reconstruction. It is very fine. So, lower limb reconstruction, let us listen to Dr. A.K. Imphal. Dr. A.K. Imphal, please.
Good morning, respected chairpersons, esteemed delegates. After the thought-provoking presentation by Dr. Soni Lingdo, mine is rather a little bit primitive, I should say, because it is not that innovative, and I'm going to speak on lower limb reconstruction as we do in the Institute. I should be thanking Dr. Salam Ranbir for giving me this slot to speak on the topic of lower limb reconstruction. Little bit of introduction. All of us are human beings, and as humans, we have adopted the bipedal posture. That is, our lower limbs are modified for weight bearing, for ambulation, as well as ambulation. So the basic difference between the upper limb and lower limb of we human beings is that the lower limb has become very big in size, and it has to bear the full weight of the body, and it has to support and it has to help us in propulsion, that is in walking and running. So the most challenging of all body regions to reconstruct, meaning thereby we have to restore the ambulatory function. Merely reconstructing and the patient not able to walk is not the answer. And we have to ensure long-term retention of vital structures. We have to ensure that the reconstruction that we have done provides protective sensation in the form of pain and touch. Otherwise, the patient will keep on injuring the structures like the foot. And at the same time, we have to obtain a satisfactory appearance to the patient. So in the past, amputation was mostly the answer to any mutilating lower limb trauma. But with time, the limb salvage procedures have developed, and with the advent of microvascular surgery, like vascularized bone grafts, then other techniques like Elizarov, which the orthopedic surgeons, they adopt, and the tissue expansion by the plastic surgeons, the perforator flaps, and the advances in microsurgery, we have been able to salvage many mutilating, many debilitating lower limb trauma. So, as I've already told, that the unique features, it has to suit to the weight-bearing requirements, and because of the dependent position, the lower limb, it takes the full body weight while standing, so it is prone to venous stasis, edema, and deep vein thrombosis, and all those problems. Atherosclerosis, the incidence is quite high, and the length for nerve regeneration has to be taken into account, because when we repair, say for example, a sciatic nerve at the like if there is a bullet injury through the thigh, the proximal thigh, or even the gluteal region, the time it will take to regenerate is pretty long. So we have to think of other options. And the subcutaneous location of tibia makes it particularly prone to injury, because one border, one surface, the anteromedial surface of the tibia, that is known as the shin, is subcutaneous throughout. So whenever it is injured, the chances are very high that the bone is exposed, and it always requires some soft tissue cover. So I will not be going into much detail of the details of all the anatomy, because the crowd is not a student crowd. So all of us know that the thigh has 3 compartments: the extensor, the flexor, and the adductor compartment. Again, the leg, we have 3 compartments. Again, posterior, anterior, and in the leg it is just the opposite. That is the lateral compartment. We don't have a medial compartment, we have a lateral compartment, that is a peroneal compartment. And different nerves and the vessels running in those compartments have to be properly studied. So the arterial anatomy, the external iliac artery from the pelvic region, it continues down as the femoral artery in the thigh beyond the inguinal ligament, and this common femoral artery, it gives the deep femoral artery, also known as the profunda femoris artery, that is responsible for the vascular supply of the back of the thigh, and the superficial femoral artery runs down and continues as a popliteal artery, again which divides into tibioperoneal trunk and the anterior tibial artery. So all these arteries, again, they go on to the foot and they divide. The posterior tibial artery divides into 2, medial and lateral plantar, and the anterior tibial continuing down as the dorsalis pedis artery. Nerves are very important. It's the sciatic nerve that is going to supply the back of the thigh as well as the entire leg and the foot. Only the anterior compartment of the thigh is supplied by the femoral nerve, but the sciatic nerve is the main supply. So when the sciatic nerve is injured, the patient will have a tough time. So tibial nerve is nothing but one of the terminal divisions of the sciatic nerve, and it innervates the posterior compartment of the leg. The venous anatomy, again we have the long saphenous and the short saphenous systems which drain the whole of the lower limb. Then reconstruction. Soft tissue reconstruction, what is the problem? What form of coverage, given the individual circumstances, will provide the most functional and aesthetic result rather than perform the simplest procedure? As we all know, we have now the reconstructive escalator or the reconstructive elevator. Gone are the days when we used to follow the reconstructive ladder, that is starting from the simplest and proceed step by step to reach the most which is difficult. So starting from primary closure and secondary closure by secondary intention, and those skin grafts and flaps, local flaps, regional flap, free flap. Instead of going step by step, walking up the reconstructive ladder, nowadays if any reconstruction requires microvascular surgery, then we have to directly go to that level. That is called the reconstructive escalator. So reconstructive ladder is, I'm not saying that it is not followed nowadays, but every plastic surgeon has to ascend this reconstructive ladder, starting from the simplest and reaching the most complex. But as I have told, reconstructive escalator should always be kept in mind. In general, the thigh do not require flap reconstruction because the muscle, it is covered with muscle all around. The thigh has only one bone, that is a femur, and it is enveloped by a good amount of muscle all around. The muscle in the anterior compartment, posterior compartment, and the medial compartment, and in the gluteal region also we have many muscles. So the primary utility flaps in the thigh are the tensor fascia lata, which is used for coverage of, say, trochanteric sores. Gracilis muscle is a muscle in the adductor compartment that is known as a watchdog of the perineum. This is a muscle which can be taken as a free flap as well as a pedicle flap, meaning thereby a flap which is the gracilis muscle is still attached to its origin and it is detached merely from its insertion, and its blood supply and nerve supply are kept intact, and it can be used to reconstruct the vagina. It can be used to reconstruct the neosphincter of the anal canal after operations on the anorectum. Then rectus femoris is a muscle of the anterior compartment of thigh, vastus lateralis, biceps, posterior compartment. All these muscles can be used as flaps. So this is the case of post-necrotizing fasciitis raw area. So quite often we come across such cases, necrotizing fasciitis, and patient, most of the time the patient is diabetic, and we land up with having such raw areas. So they can be easily covered with a split thickness skin grafting. No need to do like a flap. And we have a lot of post-burn raw areas. They're all covered by the split thickness skin graft. Now there is a 45-year-old patient who came all the way from Tamenglong with a fungating tumor in the left gluteal region. So this started in the middle of the COVID pandemic, and the patient could not get access to like the healthcare because of the COVID. He didn't think of moving out. So it was there for 2 years. And even I put up this picture in our Mumbai plastic surgery group, and they straight away advised that this will have a hindquarter amputation. So just do a hindquarter amputation. That means take out the whole femur and even a portion of the pelvic bone. And if you can keep some anterior thigh skin, then use that skin as a flap and cover, and the patient will be rehabilitated thereby faster. But we do not do that. So we had ordered an MRI, and the patient was lucky in that that tumor, it was a soft tissue sarcoma, and it had not metastasized far and wide, and even the sciatic nerve was not involved. So we dissected the whole tumor in toto nicely, and we did a V to Y total thigh flap. That is, it is an advancement flap. It is not a free flap. We advance the whole skin of the thigh just from the popliteal fossa up, and with the VY advancement we could cover the whole defect in the gluteal region. And later on the patient underwent adjuvant radiotherapy in the Department of Radiation Oncology RIMS, and the patient is now ambulatory and doing well, and he can walk. This is a case of a femur defect. Femur defect meaning thereby the patient was a 19-year-old girl from Farzal district, which was separated from Churachandpur district. 19-year-old girl, and when the patient was brought to our OPD, as she could not walk, she was carried on the back by her father. It was a sight to behold. So the patient was sent by one doctor from Churachandpur, who is an orthopedician, and we did a free fibula flap. So a free fibula flap was done, and the free fibula, since the size of the fibula is smaller, the diameter of fibula is smaller as compared to the femur, so the fibula was docked. Docked means the fibula ends were put inside the cavity of the femur by making it broad. So the docking was done, and we anastomosed the peroneal vessels end to side to the femoral artery and to the vena comitatus of the femoral artery. This came in the newspaper 1 year ago, around this time only. So now the girl is ambulatory, the girl is walking. So this was the fibula graft that was harvested from the contralateral leg, sorry. Because why we chose the contralateral leg? Because it was a two-team approach. So the recipient site was prepared by the orthopedic surgeons, and we harvested the fibula from the opposite leg and along with the peroneal vessels, and we did the anastomosis. After the orthopedic surgeons, they by a lot of traction, they could recreate the raw area. Because what happens after a long time, the whole thigh is shortened, and they had a pretty tough time putting traction and pulling the muscles apart. So again, this is a case of trochanteric bed sore. Trochanteric bed sore, this patient is completely, apart from being paraplegic, the patient has not regained consciousness. The patient underwent a craniotomy in some other hospital, and since the last 10 months he is like unconscious. She can open her eyes, but she's not able to speak. So the patient party insisted that the flap, the bed sore be covered. So this is the bed sore post-excision. The trochanteric bed sore, all those granulation tissue, everything was excised. And after excising, we did a tensor fasciae lata flap. So tensor fasciae lata is considered as the muscle of the gluteal region, and based on its blood supply from the ascending branch of the lateral circumflex femoral artery, the skin overlying the tensor fasciae lata is taken as a flap, and it is transposed into the defect. So this is the immediate post-reconstruction defect, and now it is already 15-20 days post-op, and we have started removing the sutures, but the only thing is that the patient is still to regain consciousness. In the leg, we divide the leg. Lower leg means the portion between the knee joint and ankle joint. It is divided into thirds. So upper 1/3, middle 1/3, and lower 1/3. And there are set flaps for coverage of upper 1/3 defect, middle 1/3 defect, and lower 1/3 defect. So in the upper 1/3, we usually do the gastrocnemius muscle flap. For the middle 1/3, we adopt the soleus muscle flap. Both of these are muscles in the posterior compartment of the leg. And for the lower leg, that is the lower 1/3 of the leg, the local flap options are very limited because all the muscles which are present in the leg have become tendinous by the time they reach the lower 1/3. So the only options left are either do a cross leg. Cross leg flap means we take a flap from the opposite leg and keep the legs joined together for 3 weeks, which is very incapacitating. So most of the time we do a free flap. So this is the lower limb defect in the lower 1/3. So this is a sort of a rotation flap. So we rotate the whole skin along with the deep fascia of the leg. It is lifted, it is dissected as a unit, and it is rotated along this semicircle into the defect. So the exposed tibia is covered, and even the secondary defect is also closed primarily in case of rotation flap. So after doing the rotation flap, everything is closed primarily by mobilization of the tissues. So this is the after the closure of the defect by the rotation flap. This is again a lower limb defect. So if there is a defect in the lower 1/3, what we can do is we can take one of the muscles of the lateral compartment of the leg. That is, there are two muscles. One is the peroneus longus, and the other one is the peroneus brevis. So this peroneus brevis can be sacrificed. It can be sacrificed, so we detach the peroneus brevis from its insertion, and we take it down, safeguarding all the while the superficial peroneal nerve. Then we take the muscle, and the muscle can be taken to wherever it is intended to cover, and we put a skin graft over the peroneus brevis muscle. And the sacrifice of this muscle does not leave behind big functional deformity, because the peroneus longus is still left unharmed. So this is the muscle which is taken down, and the muscle is just flipped into the defect in the tibia, and it can be grafted. But the thing is that the defect size has to be really small. For big defects, peroneus brevis cannot cover. So this was a tibia defect. Again, most of these tibia defects are because of chronic osteomyelitis. Because of the chronic osteomyelitis, the bone has been eaten away, so there is a gap in the bone. Many a time, the orthopedic surgeons, they tried distraction osteogenesis and lengthening, but when the non-union is there, then they refer to us, and free fibula is always the answer, although it is very tedious, and dissection and the anastomosis, it takes a lot of time, but once the fibula survives, then the results are very rewarding. And coming to the foot is again, it is modified to bear all the entire weight of the body and to help the body in walking and running. There are 28 major bones, 31 major joints, a lot of intrinsic muscles. There are 4 fascial compartments, and the muscles are arranged in layers, first, second, third, and fourth layer. We divide the foot, that is for the purpose of ease of reconstruction, into the Achilles tendon area, the ankle and foot dorsum. And we have the plantar forefoot, that is the anterior part of the sole, then the plantar midfoot and the plantar hindfoot. Plantar hindfoot is the most challenging part as regards to reconstruction, because the heel, it bears 2/3 of the body weight. So this was like a girl, just 8-year-old girl who came with her father one day before the Yaosang to buy some clothes, and she was just run over by a truck. So there was a degloving, and it was a very severe degloving. The entire hill pad was avulsed, but we just wanted to manage conservatively, so we took her to the operation theater, gave her some local anesthetic injection, and we did a thorough debridement. After washing it 4 or 5 times, along with all the hydrogen peroxide and the normal saline and betadine, we just closed it, and it healed. It healed in 1 month. So the patient is now able to walk. She is going to school. So again, an avulsion injury, small avulsion injury, sometimes you may think that there's a lot of tissue loss, so you have to be very vigilant and see that the tissues may be displaced. So whatever the tissues are gone here and there, you have to bring them together, and the resultant defect will be very small, and it can always be we can escape with a skin graft, provided the paratendon covering the extensor tendons are intact. Then again, this is a defect. We have a lot of diabetic patients. Manipur is, emerging as a diabetes capital of the country. We have a lot of diabetic patients, and again, we have a lot of CKD patients also because of diabetic nephropathy. So diabetic foot is very common. So from the surgery department, a lot of cases are referred to us, and this was covered with a cross leg flap from the opposite leg. So cross leg flap was done, and the opposite leg flap was raised and attached for 21 days, and after 21 days it was divided. Now the patient has started ambulating. Plantar hindfoot region is the most challenging. It is a specialized location, I have already told, and for the plantar hindfoot, we have different flaps. The one flap is the medial plantar flap. The beauty of the medial plantar flap is that it provides same quality skin as the heel skin, because the heel skin is the entire skin of the sole and palm is called glabrous skin, that is devoid of hair, and this glabrous skin cover, it is available only in the this medial plantar region. And why we can harvest the flap? Because that part of the sole does not bear weight. It is non-weight bearing. So the medial plantar artery is one of the terminal branches of the posterior tibial artery. So based on the medial plantar artery and the cutaneous nerves that supply the region, we can take a flap. It is a pedicle flap, and we can rotate it into the heel region. So this was a case of malignant melanoma of the sole. So we have done a wide local excision of the malignant melanoma. Then we harvested the medial plantar artery flap, and for the donor area, we can always put a skin graft because that will not bear weight. And we have one flap taken from the leg that is called the reverse sural flap. Sural flap, sural means the calf. Why it is reversed? Because the flap is based like distally. That we cut everything from the above, and we leave the flap attached to the lower part of the leg, because the blood supply comes from the peroneal perforating arteries. So it can be used to cover.
Excuse me, Dr. Imphal, time almost.
Yes, sir.
Can
yes,
you
sir.
wind up?
So I'll just show the pictures. This is the reverse sural flap for diabetic ulcer over the heel, and this is the inset, and the sural artery flap for diabetic foot ulcer. These are all sural artery flap. Then again for melanoma excision, these are all the sural flaps. Then free flaps. Free flaps. This was a run over accident. So we harvested the latissimus dorsi muscle from the back. Before harvesting the latissimus dorsi muscle, we have to really tell the patient that you're going to lose, you're going to have a disability as regards your upper limb function. Once the patient agrees, we go ahead and we anastomose the posterior tibial artery end to side with the thoracodorsal artery and latissimus dorsi, the draining thoracodorsal vein into the long saphenous vein. So this is the late post-operative result. We always cover it with a skin graft. So again, a lady from that Kangchupchiru village, she came with a diabetic foot ulcer like this. We did a latissimus dorsi flap and it's covered with a skin graft. Then post-operative result is like this. The patient is now able to walk. This patient came all the way from Ukhrul when he was run over by a water tanker. Everything, all the bones were apart. So orthopedic surgeon said that it is better to amputate. I said, please fix all the bones and let me try a latissimus dorsi flap. So we harvested latissimus dorsi muscle, took from the leg, done the anastomosis, and covered, wrapped the entire dorsum of the foot with the flap and put a split thickness skin graft. Now patient is able to ambulate. Another flap that comes handy is the anterolateral thigh flap. This is from the thigh. The good thing about this flap is that the donor side morbidity is very less because we're not sacrificing any muscle. It is just the skin and the subcutaneous fat and the fascia. So this is the ALT flap, and we are not sacrificing a major blood vessel also. It is based on a single perforator. The only disadvantage is that the vessel size sometimes is quite small. So the relevant points are the selection of an appropriate flap procedure. We have to think beforehand. Local flaps, island flaps, all those flap options we have to think before we embark on a big procedure. If there is lack of local tissue and if the defect is really large, then there is no other option but to do a free flap. Fasciocutaneous flaps in thin patients and patients who are males who have very less amount of subcutaneous fat, the fasciocutaneous flap really come with a tailor-made like thinness. Muscle flaps with STSD, that is a split thickness skin graft, are the best choice in defects of the weight-bearing areas of the foot. Thank you so much.
Thank you, Dr. Imphal, for your nice presentation with elaborate explanations and the beautiful pictures. Thank you, and we invite now only one question from the audience because of lack of time. Any question? Okay, congratulations. Okay, we pass on to the next presentation.
A very good morning to everyone. We have come to the third speaker of this CME number 2. Will be presented by Dr. Ranjita Angom, and she'll be talking on spectrum of advanced gynecological laparoscopy.
Good morning, respected chairpersons, esteemed seniors, and my dear colleagues. So I'll be covering on the topic spectrum of advanced gynecological laparoscopy. As we all know, this is the era of minimal access surgery, and it is minimally invasive, and we use a telescope called laparoscope to visualize the pelvic area. Especially in gynae, we are more concerned about the pelvic area. So we use this minimally invasive procedure as a diagnostic as well as therapeutic or both. And it is slowly replacing the open surgery in view of shorter healing time and the smaller scars. Today I'll be covering on the following topics because this is less ventured upon in our Manipur, but our Manipur State Chapter is also not far behind under the able leadership of Dr. James Elangbam, consultant ECME Hospital. And we are trying to keep update about all the procedures which is being done by the counterparts in the rest part of the country as well as the world. So we have already done laparoscopic proximal neovaginoplasty using the latest Davidoff technique. And we also have done laparoscopic sacrocolpopexy. Wardimes can also be done laparoscopically, and I think very few gynecologists here are doing Wardimes hysterectomy. laparoscopic myomectomy, when it is a submucosal also, we can do laparoscopic myomectomy. This I'll be showing in the subsequent videos. As many pregnant ladies, they undergo cesarean in Manipur on demand. There is increased incidence of isthmosil. So isthmosil can also be repaired by laparoscopy. My first case was a 27-year-old, a known case of Meyer-Rokitansky-Kuster-Hauser syndrome with vaginal agenesis and infantile uterus. So her chief complaints was there was no mens since puberty. And she came to us just because she was having pain abdomen, periodic pain abdomen on and off since April 2022. On investigation, all her investigations were within normal limit except the ultrasound. The serial ultrasound starting from April was showing a left adnexal complexes, which was gradually increasing, and she came to us in July 2023 with the complex ovarian cyst of the size of 9.5 by 7 centimeter. MRI, however, confirmed she is a known case of Mullerian agenesis. Hormonal study were normal. Since the ovary was present, all her hormonal profile were normal, and she is of female karyotype. With this diagnosis, we went ahead with laparoscopic ovariotomy and vaginoplasty. We used the peritoneal pull-through procedure using Davidov's technique. So while doing the laparoscopy, infantile uterus, left ovarian endometrioma was confirmed. However, the tubes and the ovaries were normal, and on the right side only the tube was present, left it was not visualized. So in this case, we started with mobilizing the rectosigmoid by adhesiolysis of the congenital adhesion of the sigmoid colon, and the left endometrioma was removed along with the infantile uterus. On the right side, the fallopian tube was vestigial because it was not connected to the infantile uterus, so we removed the right salpinx, right fallopian tube. And after removing the ovarian endometrioma and the infantile uterus, we went ahead with creation of the anterior and posterior peritoneal flap. After creating the peritoneal flap, we introduced a vaginal mole, deepening the patient had only a dimple of the vagina. So we give incision laparoscopically from the above, and then the upper border of the vagina is sutured with the peritoneum anteriorly, and similarly the posterior also we sutured the peritoneum with the upper margin of the upper margin of the vaginal wall. Then the bladder was separated from the bladder was separated and pushed down. After that, we in order to create the upper border of the neo-vagina, we put up purse string suture. Excuse me, sir. I need a technician. The video is not playing. I wanted to show in the video. I need a technical help. Okay. Okay, this is the intraoperative finding. This was the left ovarian endometrioma. After incision, the chocolate-colored cystic fluid was aspirated, and we excised the cyst, endometriotic cyst. After that, this is the infantile uterus, which was also removed because it serves no function. Right side, this was the salpinx which was neither attached to the uterus, so this was also removed. And anterior peritoneal flap was already created. This is the, we are creating the posterior peritoneal flap. Here we are giving a incision over the peritoneum, and this is the mole inserted per vaginum. So we have created the new vagina with the help of a vaginal mole. This is nothing but condom with gauze piece. So in order to create the upper border of the new vagina, we have given a purse string suture of the remaining peritoneum. And peritonealization was done. And the mole was kept for another 2 weeks, followed by, along with the silicone catheter. And after 1 month, patient was given a dilator to dilate 5 times a day, and she continued for 1 month. After that, right now, she already has achieved 2 centimeter dilatation with 8 centimeter length vagina, which is an anatomic success. And the specimen were retrieved using palm oscillator as well as endobag. And patient right now has achieved the anatomic success, so she can marry and at least we fulfill the sexual function. So many cases of MRKH syndrome can benefit from this vaginal neoplasty. The blood loss was only minimal, 300 ml, and intraoperative and postoperative period was uneventful. Right now she has completed 4 months, and we have done a vaginoscopy to see the epithelialization, and this was the picture. The vault is already healed and epithelialization has already taken place. So this opens a way for all the MRKH syndrome with vaginal agenesis. The second case is a case of 59-year-old para-2 leaving to abortion 1 with vault prolapse. She underwent hysterectomy in 2013. Intra finding was that we could see the vault prolapse, and in this procedure we also separate the This is the procedure which we do. Through the vagina, we inserted a sponge and then make the vaginal wall prominent. And in this procedure, we separate the peritoneum anteriorly as well as posteriorly 5 centimeters below the apex of the vaginal bolt. And with the help of a propylene Y-shaped propylene mesh, one limb of the Y will be stitched to the anterior vaginal wall, and the another limb will be sutured to the posterior vaginal wall. And the upper part will be pulled up, and it's sutured to the anterior longitudinal ligament of the sacral promontory, maintaining enough traction not to cause avulsion or and to suspend the vault properly. So this we are suturing with nylon over the anterior and posterior vaginal vault. After suturing the propylene mesh and suspending the vaginal apex, the peritonealization is done using ethibond. Ethibond is nylon 20. So, any vault prolapse can also be addressed with laparoscopic sacrocolpopexy. She was discharged on post-op day 2. Recovery was uneventful. Third case was a 75-year-old para-5 leaving for abortion 3 post-menopausal known case of hypertension and hypothyroid. She underwent laparoscopic Wertheim cystectomy for CIN2. And in this procedure, we start with devascularization of the uterus by clipping the internal iliac artery. So here, internal iliac artery is isolated and skeletonized, and then it's coagulated. Then we went ahead with, this is on the other side. Then we went ahead with total laparoscopic hysterectomy, starting with the infundibulopelvic ligament. And anterior lip of the broad ligament, here we are dissecting the anterior lip as well as the posterior lip. The anterior lip will go up to the UV fold, and separation of the endopelvic fascia and the bladder is pushed down. So this is a separation of the bladder from the cervix as well as the upper vagina. Here we take special care to dissect little bit more down than the normal total laparoscopic hysterectomy which we do for benign cases. Because we have to resect 2 centimeters, in radical hysterectomy we have to resect 2 centimeters of the vaginal vault. Here we are dissecting and skeletonizing the uterine artery. Coagulating the uterine artery. Now we open the vaginal wall 2 centimeters below. Here, because we don't want any recurrence from the vaginal vault, so 2 centimeters is excised. With this blue thing is the colpotomizer, which we introduce vaginally, and it will guide you where to give your incision. This procedure we are doing the lymph node dissection. The external group of external iliac, internal iliac, and the obturator lymph nodes are also done. Bilateral pelvic lymph node dissection can also be done laparoscopically. So visualization is better, and you can dissect more completely because it is visualized better in the deep pelvis. So this is lymph node dissection. The specimen of the uterus is retrieved vaginally with the help of a valsalum, and the lymph nodes were separately taken out using the endobag. So this is the endobag. We have already loaded all the lymph nodes. And the vaginal vault is closed using barb suture. We use V-lock here. And we put an intraperitoneal drain to drain the excess fluid or any bleeding which we anticipate. So she had recovered uneventfully, and she was discharged on the course of day 3. Drain was removed on day 2. But however, she had less blood reserve, so we had to transfuse 2 pint PRBC. My 4th case was a 35-year-old premenopausal lady, a case of submucosal fibroid. The fibroid was not visible laparoscopically, but it was evident from the ultrasound which we took. Any case of fibroid, we have to do a laparoscopic, this one we have to do a compulsory ultrasound scan by yourself. So that's how you confirm the location. And this patient, she had been having heavy mens for the last 2 months with passage of clothes. And in the procedure, like we could find adenomyotic uterus. Here it looks, this is adenomyotic uterus. And first we start to reduce the vascularity of the uterus. This is internal iliac artery ligation, clipping. We did clipping for this case. This is the right side. Right uterine artery was clipped, and similar clipping we did on the left uterine artery. Then next we proceeded with injection of diluted vasopressin into the myometrium. This will further reduce the blood loss. We don't want any blood loss in her case because she was anemic and her hemoglobin was only 8.3. So after giving incision on the anterior uterine mucosa with the help of a hook monopolar, we could see the fibroid from inside, and with the help of myoma screw it was taken out, dissected properly, and closure of the defect was done in 2 layers using barb suture. And especially in case of myomectomy, we don't want any further adhesion, so we use intersheath to prevent further adhesion. We want fertility in her case. She had only 1 baby, so we take extra precaution not to cause adhesion. So this is the final picture. We relook in the clipping of the right uterine artery, and on the left side, final relook. So any case of submucosal myoma, we can cut through and then we can, it is easier than using hysteroscopic myomectomy because we use lots of fluid and then fluid overload can take place. So the toxicity after using too much of glycine and normal saline can be prevented.
Excuse me, Dr. Ranjita, we are very much running behind schedule, so please try to complete your presentation.
Yes, ma'am, I'm done. My 5th case was a total laparoscopic hysterectomy, and in this case we had to retain the ovary, so we start dissecting, we start coagulating and cutting from the mesosalpinge. So I will not be showing the normal TLH. My last case was a laparoscopic isthmosil repair. Isthmosil repair was done for secondary infertility. She is 39 years old and para-1 and she wants to conceive. The cesarean was done 9 years back. So I'll just show you a short video of the isthmosil repair. It is just like a myomectomy. First, this is a shearer which we are using here. Shearer takes care of sealing the vessel also. So this is separation of the endopelvic fascia from the bladder, and we locate the isthmosil with the help of hysteroscope as well as the laparoscope. This is the isthmosil which we are just seeing, and the isthmosil part is resected and suturing was done of the myometrial layer. And we had followed up this case and we had done ultrasound. The isthmosil was resolved. So we can plan for IVF or IUI depending on her ovarian reserve. So most of the patient was discharged on day 2 or day 3. My take-home message is minimal access surgery should be popularized in view of avoiding large open wounds. We reduced the blood loss, the pain and discomfort was reduced, and in the long run, adhesion was also reduced, and the recovery time is reduced and of shorter hospital stay. So this question is left to the audience. Thank you.
Thank you. We can have one question for this session.
I'm interested, Dr. Ranjita, excellent presentation. I'm interested in your first case. How does that vaginoplasty compare with MEC endovaginoplasty when we used a skin graft?
Skin graft actually, problem is with the take-up. Most of the time the skin take-up is very poor compared to the peritoneum, because peritoneum we are not disturbing the blood supply. We are just pulling it down and then attaching it to the upper part of the vaginal wall. So the uptake is better since the vascularity is not preserved, and it is an autologous tissue, so it gets taken up easier. And it is the latest upcoming vaginoplasty compared to the rest of the vaginoplasty. We can use amnion graft also, I think, which most of our senior gynecologists were using it. but failure rate is high, and the tissue retrieval is also very poor. Like we have to coordinate with the one delivering in the labor room. So which vaginoplasty, they may not be taken up at night time if in case like we can take the tissue at that time. But for peritoneal pull-through autologous one, we don't need anything from anybody. So it will be just the one individual's tissue. So the take-up is better, and it is the most popular vaginoplasty which is ongoing here in Manipur, in India. This has been taken place since 2016, 14 to 16 in other parts. But in Manipur, we have just started under the expertise of Sir James, and I think this is a good initiative which we have taken up here.
Bound. It was really, I mean, I also feel that minimal access surgery must be in vogue. But this particular question you have asked, open surgery do have role. Sometimes while you are doing this thing, laparoscopic or minimal access, conversion has to take place because sometimes it's so adherent. I mean, so we must not feel that I have told the patient I will do laparoscopy and I will continue at the risk of the patient. So that this question, of course, open surgery is much reduced. Once upon a time in my specialty, lower uterine stone, Robindro was working with us, and that time it was so difficult. You can't get a stone also. While trying to palpate a stone crumble, and when you open the ureter, you don't get a stone. And you don't have a stone to show to the patient party. A lot of problem, hematuria, pain, as you, the advantages you have innumerable. Among the advantages, I just want to enumerate, very comfortable for the patient, for the surgeon also. You didn't mention it is very, doing laparoscopy or endoscopy is poles apart from the open surgery. Anyway, wonderful, Ranjita. Where is our James? Oh, James, you must stand up. He was, you are doing a wonderful job. Very good.
Thank you, Dr. Ranjita, for this wonderful presentation of the different spectrum of gynecological cases done under laparoscopy, and for the wonderful videos too. Thank you very much. Okay, now we have come to the conclusion of this CME number 2.
Thank you, respected chairpersons and speakers. Now to felicitate the speakers of the CME, I would like to call the chairpersons, Dr. S. Robindro Singh, Dr. Jasobanta, and Dr. K. Sushma to proceed towards the right side of the stage to felicitate the speakers. And to felicitate the chairpersons, I would like to call on Professor Sinam Rajan. Okay. And we would proceed to the next CME, for which I would like to call on the following chairpersons. First of all, I would like to call on Dr. Y. Iboton Singh, former head of Department of Medicine, Jennings, Imphal. And I would like to call on Dr. Shyam Kumar Laishram, past president, IMA Manipur State Branch, to be the chairpersons of this next CME. Sir, please. This one, they will first, and that was this one.
for our next CME, we are already behind schedule. We have Dr. L. Shamkishore Singh Hilbit deliberating on the modern treatment of common cardiac emergencies. He is the chief of the Sky Hospital, renowned cardiologist in the state of Manipur and abroad. Dr. L. Shamkishore Singh, please.
Dr. Shamkishore.
Just play from the bed, right?
My topic is to
here. Here.
This one. Okay. Good morning, everybody. Now, we are having this pre-lunch session. The first topic will be modern treatment of common cardiac emergencies. We all know that cardiac problems are the largest killers. So, in fact, it accounts for the majority of mortalities in the whole world, also in India. So, it is very important that we should be able to tackle the common cardiological emergencies. So, about this topic, Dr. Shamkishore will be speaking. You know, Dr. Shamkishore is one of the leading cardiologists of the state, and in fact, he started his career as a junior resident in my unit. Then he did MD, DM, and he went to London and did MRCP, and in fact, he is one of the, leading cardiologists. In fact, he was one of the members drafting the common cardiological emergencies in UK. I am sure his talk will be interesting, educative, and illuminating. Dr. Shamkishore, please.
Thank you. Respected chairpersons, ladies and gentlemen, I spent 40 years of my career outside Manipur, and my expertise, and out of that 15 years in the UK. And my expertise benefited people and students and doctors over there. On coming back to my home state, I thought I would try to benefit my people, my medical students, young, enthusiastic doctors and medical fraternities of my state. So here I am. Although I remain very busy at Sky Hospital, dealing with these cardiac emergencies, and as we go, I will share with you my experience, and also will keep talking to you how we can advance and progress in the field of cardiology and cardiac surgery. It was 1995 when I went to London, and when I started to work there, as Tamo Iwoton has highlighted that cardiovascular disease is the commonest cause of death all over the world, including India and Manipur. Till 1995, till 1998, there was hardly any guideline on common cardiac diseases, including acute coronary syndrome. So I look for guidelines because in the UK, if you follow guidelines, you are protected. Well, not protected, but the law code over there is called coroner's code. Fortunately, the coroner's code, the judge has got to be an expert in forensic medicine, and also he has to be an expert in law. So you get a lot of support. Well, if not necessarily support, but it will be very much neutral, and then you will get the judgment from the person who knows about medical science. So then, to follow the guideline is preferred, and then that is mandatory as of now in the West. In India, it is coming up, but it is probably not mandatory as of now. So there are two practices. One is called evidence-based practice, that is guideline-followed practice, and opinion-based practice, that means practicing on your own knowledge. So long everything goes on well, that is fine. If something goes wrong, court will not protect you. See, so then I started looking for these randomized controlled trials, and then these other evidences to follow diagnosis and treatment of various common cardiac diseases. And I started writing of guidelines for the use of the hospital I work. And it has come up to a standard, and I showed my manuscript to two other consultant cardiologists with whom I was working, and we three of us put our heads together, and we thought this also should be put and then got published so that other doctors all over the world also will benefit from it. So we put it in, we just submitted to Oxford University Press and got it published, and it was published and became very popular, and there was no adverse comment on it, and there was no challenge so far. So that was on acute coronary syndrome. It was, and you'll get, I think I have given in my introduction the journal and when it was published. It was a long time. That was the turn of the century, this 21st century. Around that time, there was a conference in this European Heart House in Nice, in France. That was 2000 February. And I was invited as one of the delegates from the United Kingdom. 5 of us were invited, and I was one of them. You can see here, I was in the center. Always, it doesn't mean that I was the center in the decision making, but somehow I was in the middle. And that gathering, that meeting, paved way to start making guidelines on various types of acute coronary syndrome. Treatment of common cardiac emergencies in very short period of time, it is just not possible, but I'll try to cover as much as possible, and I'll probably give you the gist of common cardiac emergencies. First, of course, it goes without saying that acute coronary syndrome is the commonest, and it is a killer disease if not accurately diagnosed and appropriately treated on time. Just if I may not get time, and then chairpersons may not allow me to continue after the time is over, so I'll just briefly mention about some other important which should not be missed, like cardiac arrhythmias. Among cardiac arrhythmias, there are supraventricular cardiac arrhythmias and ventricular cardiac arrhythmias. Supraventricular arrhythmias like ventricular tachycardia, ventricular fibrillations. It may be secondary to ischemic heart disease, myocardial infarction, or it could be the heart structures may be normal, but the electrical activities, the conduction tissues may be abnormal. It may be called autosomal dominant, it is hereditary. Like say for example, Brugada syndrome. Brugada syndrome, it is a hereditary disease. It is autosomal dominant. It occurs mostly in men. It is the cause of one of the death in sleep. And Manipuri Maglagnava na Haisi is one of the common. This Brugada is one of the common cause of Maglagnava. And previously it was thought that it was unavoidable death. Magidi Maglangna Hagadi Shivasi Maisi the unavoidable Nehana Kanaram. But now with time now we have discovered that Brugada syndrome is one of the causes of this sudden cardiac death during sleep, and it is due to ventricular fibrillation, and it is preventable by just putting an ICD. So similarly, say hypertrophic cardiomyopathy, it is again hereditary, and it is autosomal dominant, and it causes ventricular fibrillation and kill if not detected on time, and that is preventable. So these are common causes of sudden cardiac death. And if put in ICD, and that will prevent the ventricular fibrillation, and that will prevent the sudden cardiac death due to ventricular fibrillation, and then patient will survive. The individual will survive. They may look normal. The patient will go to bed, and then next day when somebody goes in and check him, and he doesn't get up, so he's dead during sleep. That should not take place. So we should be able to prevent that. Sudden cardiac death survivors, I have mentioned about this. Say sometimes if the patient's rhythm and rate and rhythm returns to normalcy within minutes, then patients wake up on his own. So these patients are called sudden cardiac death survivors. So we'll have to take it very seriously and to take the matters further to find out why. I got a patient, 27-year-old young man from Sagolwan, and he came to my emergency, to cardiology emergency in Sky at about 6:37 p.m. He looked normal. And when the ECG was done, fortunately for me, and I got one ventricular ectopics, all sinus rhythm. And the history was very typical. See, I must emphasize to the young generations that we should not ignore physical examinations. You must use your God-given sense, these special senses, your eyes, your ear, your touch. So all these things matters. And so when the history was very typical of cardiac syncope. The patient had completely LOC, loss of consciousness, and recovered in less than 3 minutes. So with that history, and then the one ventricular ectopics was enough for me to mentally make up my mind that it was ventricular tachyarrhythmic related syncope, LOC, loss of consciousness. So I advised him for admission, for observation, for further treatment and management. The patient looked very, very fit, 27-year-old. Parents were ready for admission. The other people in the group, they probably thought that he doesn't look ill, so they took him home. At 12 midnight, the same recurred, so he lost consciousness. He was taken to another hospital, and he was brought back home. The third episode killed him at 3 a.m. See, this could have been prevented. We'll move on, because time is very short. So, I'll talk about acute coronary syndrome. As you know, this is a coronary artery disease when it manifests acutely and is about to kill the individual, then it's termed as acute coronary syndrome. It has been coined more recently. Previously, it was not there. When I was a student, it was not there. When I became a cardiologist, then it has been being used. The prevalence, the recent prevalence data is not available, but this gives you an idea about this coronary artery disease. The prevalence is more common in the urban area, almost double that in the rural. the burden is still high, and interesting and important publications from the Indian Council of Medical Research journal, and one of the authors was the Dr. Balram Bhargav. He was the Director General of Indian Council of Medical Research during the time of COVID pandemic. You know him. He was from AIMS and about 5-6 years junior to me. And in 2022, that was published in 2022. According to that study, in that journal, the study by the Indian Council of Medical Research and the Registrar General of India accounts for approximately 60% of the world's heart disease burden. You can very well imagine how serious it is. So coming back to the ACS, it encompasses 3 groups. One is acute ST elevation myocardial infarction, others is non-ST elevation MI, and third one is unstable angina. Unstable angina is on the way to develop myocardial infarction if you don't treat appropriately at that particular time. This is we just made it just to make it simple, that you from echocardiogram. First is the symptom of acute coronary syndrome. First manifestation is chest pain. Then second is electrical changes, that is changes on the ECG. Third one is the cardiac markers. If the ECG is quite prominent, the patient has got typical history of myocardial ischemia, that is enough to diagnose myocardial infarction as per the definition of World Health Organization. You start treatment because every minute, every second counts, and you have heard about this golden hour to treat acute coronary syndrome, acute myocardial infarction, but 1 hour may be too much, and if you can start earlier, the better the prognosis and outcome is. And if the ST elevation may not be present, but the history is typical of myocardial ischemia and then ST depression or T-wave inversions, so these are group as non-ST elevation myocardial infarction. The treatment is entirely different. You have to you go for the ST elevation and myocardial infarctions. You have got 3 options. I'll come to you that, and then non-ST elevation MI. That is that the treatment, the stem is different, and then unstable angina. Of course, it is again you have to treat it aggressively, but how to do? It's just to recapitulate what you will see on ST elevation MI. I had a patient 3 days back. Patient was taken to one hospital in Imphal, and then ECG was done at 9:43 p.m. and then that itself shows ST elevation in the region of the right coronary artery territory. But somehow the patient then ECG was patient presented to the hospital at 9:43, and the ECG was given at 10:30 after about 40 minutes. That's very long wait. So this, of course, in the West, in the UK, I can say, but in London area definitely there are two rows in the casualty. One for the suspected acute coronary syndrome. So these patients, they are triaged by ACS nurses. They are called ACS nurses. There are ACS nurses all available all throughout 24 hours. And there is when you go to the airport, you have got access to go quick. So this is you don't have to wait. The patient is taken directly for diagnosis and treatment. So that I think if we make a policy that that has to go, of course I'm sure that has to go up to the higher authority, and we have to make this sort of to reduce and avoid this sort of waiting time. At 10:30 the patient was given an ECG, and then ECG itself showed ST elevation, but the voltage was a bit low, so probably the the cardiac markers for myocardial infarction was done, and then by 1:15 the first loading dose dual antiplatelet was given. So it is about 3.5 hours from presentation. So see, we should be, so that's sort of time loss, time waste. We should try to minimize. And I'll show you what is our experience in Sky Hospital. This is a simple, well, I wouldn't say simple, straightforward ST elevation MI in the region of RC, right coronary artery territory. That's simple. These are the latest guideline. Is too much and too small, but I'll make it simple. Let's talk first about ST elevation, acute ST elevation MI. What are the options as of now? As of now, we have started at Sky Hospital that HAG in London is called HAG, Heart Attack Center. We just modified a little bit, Heart Attack Treatment Center, and we started this in 2013, and then our protocol is to see patients with suspected heart attack within 5 minutes, given an echocardiogram and a diagnosis is made, and then you start treatment there. You give loading dose. You give this loading dose of dual antiplatelet drugs, and then followed by thrombolytic therapy, either starting from the emergency room or as soon as possible, the transfer to the ICU. But nowadays we started giving direct in the emergency room itself, because every second counts, and I will give you the evidence how the myocytes, how the myocardial cells die after the total occlusion, means 100% occlusion of the blood supply. This was, I thought, like as I did in 1998, I thought we should look up what we have done. I didn't know that this would be the case, the result. We just pull out those patients who had been treated at Sky Hospital over a period of 2 hours, 2 years. And then this was written and then submitted to the American Journal of Cardiology and Clinical Research, and they have readily accepted and published in 2000. In American-based, this Journal of Cardiology and Clinical Research, it is open-ended. It is openly available on internet. You can have access. If you like, we can give a copy. And this has been very popular in the West. And you know why? The survival rate was 96%. And it is more than the global average. Global average is around 91%. And then I started getting invitation from London, the Heart Congress, London 2022. This is from Paris. Is it from Paris? Yeah. It was February 2022, last year, 2 years, 1.5 years back. I couldn't go because of the COVID pandemic, and I was not very keen to travel also. And this one was this year, May, Tokyo. I was invited to give a talk on this, and then Tokyo, I wanted to go, and it was May. And unfortunately, around that time, resurgence of this COVID started, and then 1 million Japanese was positive for COVID. And then the Japanese government stopped it. There will be no gathering, no meeting. So I just couldn't go and present the paper. See, this is the paper I'm talking about. Choosing the right model for SC myocardial infarction care in India. Focus should remain on providing timely fibrinolytic therapy for now. So this was published only last year, and the Journal of the Indian Journal of Medical Research, and then the author is the Dr. Balram Bhargava, the Director General of Indian Council of Medical Research. And this I have already published in 2000, and it is telling actually why should we choose this as of now, is because of the following fact, that primary PCI, primary percutaneous coronary intervention, it sounds nice, and if it can be done within 120 minutes from the time of onset of symptoms to the balloon inflation, if you can achieve that, how many patients can avail that opportunity? How many patients we can give benefit of that? It's a very hard work. Not only the availability of cath lab, but manpower. It cannot be. You cannot do on your own. If you are competent in doing the coronary angioplasty, but you need staffs. There are 4 to 6 people are required. And then in the middle of the night, usually it is commoner in the early hour of the morning, the myocardial infarction, as you already know. And during that time, to gather, to bring all these people at one time, it is just not possible. That is one thing. Secondly, about the non-availability of the infrastructures. Number 3 is non-availability of the experts. So that leads to leads to the availability. That means the availability of these services to the patients who are suitable for this primary angioplasty and primary PCI. That is available only in 5 to 10% of Indian population in all over India. As of 2022, I'm talking about very recent, latest. And what happened to the West? In the West, it is no different much. In the West also, only up to 15% of all patients suitable for primary PCI receives primary angioplasty because of all these factors. Please just let me know the time.
1 minute, Dr. Samkishore, your lecture is very interesting, but your allotted time is 15 minutes. Now you have crossed 20 minutes. Kindly encapsulate a little quicker.
Thank you.
We'll be very grateful
for reminding. That is why I was worried. I didn't clock today. Otherwise, I normally clock at least 2-3 minutes in advance to stop. That is. Okay, this is interesting. See, this is an experimental study when the coronary artery is occluded to cause acute myocardial infarction, and then the death of the myocardial cells in this much of time. In 40 minutes, 40% of the myocardium become non-viable. So put it that way. Okay, and then over a period of time, more myocytes will die. So then time is muscle. So that we have to act very, very fast. I tell my staffs, they run, they walk. Don't walk, run. That's so these are the graphs showing that how quickly myocytes die after the acute myocardial infarction, means total occlusion. These are the and this is post. These are the post procedure. I'll just show you. This is not very. From time to time, there are occasions when we may not be able to diagnose and see the wall motion abnormalities. There, the role of 3D echocardiography. This is from our lab, and see from different angles, and then see the wall motion, regional wall motion abnormalities, and from there also we can add to the diagnosis of ST elevation. This is called transmural myocardial infarctions, and help in treating the patients appropriately. This again I will skip, and then I also wanted just to share with you not only the cardiology it doesn't consist only of the acute coronary diseases, but also these are all related to coronary artery disease. I'll skip this. So this is another one. We have added invasive, that is PCI, coronary stenting after the thrombolytic therapy. What does, then it does improve further the chance of survival. This again we have submitted to Journal of Clinical Cardiology and the Cardiovascular Intervention based in USA. I am more popular in the West than in India and Manipur, because I've spent 40 years outside Manipur and more in the West. And this has also become quite popular, and this is available on the website. This is becoming the rule of the common strategy for treatment of acute coronary syndrome. This is called pharmaco-invasive therapy for acute ST elevation macular infarction, a viable alternative to primary percutaneous coronary intervention. This is easily done, this is easily available, rather than just waiting and looking at the primary coronary intervention, and when it is not possible. We have tried for more than 10 years and it's not possible. In the West, as I said, it is less than 15% only receive primary coronary intervention for ST elevation patients, ST elevation macular infarction patients who are suitable for this procedure. And very quickly, sir, if you kindly permit me for another minute, because this I must share with my colleagues on the floor. These are all, okay. Now, see, this patient, luckily, we were in the cath lab doing procedure. We were already in the cath lab doing procedure. That means, what does that mean? Manpower is already available, infrastructure is already there, and then patients were taken directly to the cath lab without losing any time. So this you can see here, there is complete occlusion of the right coronary artery, and then we put in the guide wire, and then you can see it's excellent, but how many patients we can offer to? See, it's like completely like a normal flow of right coronary artery. So it doesn't, see, we know that, when all over the world know that this looks good and this does good, and also it helps improve the myocardial function, myocardial function quickly, but when it's not possible, it's not possible. Now, this, I'll skip this one. And you will be happy to know that this this National Interventional Council, it is a sister body of the apex body of Cardiological Society of India. They, from their data collection, in Manipur, as statewise coronary intervention data for the year 2020, top performing centers statewise, Kerala, Madhya Pradesh, Manipur, Sky Hospital and Research Center, Imphal. We were one of the 14 top performing coronary interventional center of the state of the country, Indian nation. I'm sure you'll be happy to know that you'll be part of, you'll be happy to be a part of India, of Manipur, sorry. So this is again this is not uncommon, PSBT, and this patient's, due to, this patient has got, 13 years old patient has got absent anomaly, and at the same time has got Mahem pathway, and this patient visited another hospital off and on, and adenosine was given, reverted to sinus, and again after a month or two, returned again having the same, the palpitation, PSBT, at a rate of 180, 200 per minute, causing a lot of symptoms to the patient, the child, 13 years old. And somehow they went to outside the state. In fact, they went to Chandigarh. And then over there, after about 8 months, the same palpitation, PSBT, returned, and then went to the same hospital, and they given adenosine, reverted to sinus, and told the patient's party that the EPS and RFA done in outside Manipur failed, so that's why the PSBT returned. So this patient came to me and I said, yes, we have got this infrastructure facilities and expertise, and we will be able to do it. And this we have done, we have identified, and it was an atypical form of this accessory pathway. It's called Maham's pathway, and then this is intracardiac ECG, intracardiac electrocardiogram, and then we pin down to the very small, 2 to 3 millimeter in diameter only, very small, pin down to the focus of the palpitation, and that has got to be ablated. It is an energy, radio frequency ablation. So it is a component has got two. One EPS electrophysiological study. That means it is a mapping to find out where is the focus. And then second part is the radio frequency ablation. Radio frequency ablation, the source of energy is outside the body, and then with the electrodes we just ablate it, burn it, and then make the focus non-functional. So that is a cure. After that, the patient was on 2 very strong anti-arrhythmic drugs, flecainide and another one. And if the patient has to take, despite that, he has recurrence of this PSBT. So this is, we have been doing for the last 8 years, somehow out of ignorance probably. The patient was advised to go outside the state of Manipur. Unfortunately came back unsuccessful. That was, we have got a few, at least 3-4 patients of that kind, went to Delhi, came back with a recurrence of symptoms. That means it was a failure. It requires highly skilled experts. So this is post EPS and RFA of the child, and you can see these PWF and QRS very nicely. Now this VT degenerates to VF very quickly. If you know, these patients came with MI and then within minutes developed this VT while in the ICU, and we are very quick in giving DC shock, and the patient, the rhythm reverted to sinus and patient survived.
Dr. Samkishore, please hasten a little more, because it is more than half an hour now.
Sure.
We are running very short of time.
Thank you. If you kindly allow me this one, I'll just. This is the last slide. Can I just take 1 more minute, please? Just 1 more minute. If you start counting, 1, 2, 3, 4. Okay. So this is telecardiology. How I have thought about many things. Like I'm sure you also do. But we have to make a start. How to save time. I have seen patients coming from the hill districts of Manipur on the windy road while reaching the tertiary, reaching Sky Hospital. I already spent 2 hours, 1.5 hours on the road. How to cut short, how to give these medications then and there. So in association with, in collaboration with the National Health Mission, Government of Manipur, and with the blessings of Honorable Chief Minister of Manipur, Sri N. Biren Singh, we started this telecardiology service at the district hospitals. And we started at Chandel District Hospital and Senapati District Hospital. We have, in association also, Manipur Heart Foundation also contributed, and then we have purchased 5 machines, and 2 machines installed in Chandel District and Senapati District. And we started working, and in the meantime, the others, when we were about to install others, then this violence started, and that way we are still on hold. The command center is at Sky Hospital, and we are open for 24 hours, and we do help not only for acute myocardial infarction but also arrhythmias, and then this BT can be the cardioversions, the defibrillations can be done then and there. That's why we are trying to cover almost all part of Manipur, hopefully. So as time is I have already exceeded the time limit. I thank you, our chairpersons, and if you have got any questions, I'm ready to take on questions.
Thank you, Dr. Samkishore. It's a very nice talk. I think we'll have some session with collaboration with your hospital and with your sponsorship from your hospital in the near future. So next, thank you, sir. Thank you. Next speaker is Dr. S.S. Kala Singh. He will be talking on heart attack is preventable or not. Dr. Kala is a cardiothoracic surgeon. He was quite associated as secretary in the person of the Indian Medical Association. He was secretary in the person of the ASI and the many other associations, and got many awards both in the academic and the social. Dr. Kala, please, and sir, your time is 15. Kindly keep the time. We are behind schedule more than 1 hour. Please keep time.
Your presentation is it is preventable or not? PowerPoint. Yeah. Yes. Good afternoon, everybody. Respected chairpersons, senior members of the IMA, dear friends, students, and just invitees. Now time is, we are running, so I will take short time. Actually, I am just presenting this topic. Daily we are facing the problem of this one, and I will not take time so much. So the question arises, heart attack is preventable or not preventable? Some doctors say, yes, it is preventable. Okay. So let us see the factors which are responsible for this disease. Cardiovascular disease is public health enemy number 1, not other disease. When we add together, dying from cancer, from malaria, from together, percentage of death from cardiovascular disease is more. So we must say this is number 1. Every year, 18.6 million people die of cardiovascular disease in the developing country. And heart disease accounted for 28%, 28.1 of all deaths in India. I see my previous speaker already pointed out. But just I want to mention here that in Manipur also, the heart disease is very common, particularly in GNIMS or RIMS. Out of 100 patients admitted, more than 15 to 20% of heart disease patients there. So we must take care about the increasing incidence of heart disease in our such a small state, not in India but in Asian countries. We also have the problem. So I want to present this topic, whether we can prevent such a disease or not. Already my previous speaker already mentioned anatomy. So may I mention 1, 2 only, right blood supply. One is right coronary artery, another is left coronary artery. Let us, you may forget the right side, but don't forget the left coronary artery, because most of the heart attacks, starting from this blocking or obstructions or spasms of the left coronary artery. Right coronary artery to some extent we can tolerate, but it is on the left side, from here origin up to this junction. This is the main problem. That is why we are dying at the spot. What is heart attack? Everybody asks.
Simple word is that when the blood supply is decreased, we may say the ischemia. When blood supply completely obstructed, no blood supply, then there may be infarctions or myocardial infarctions, or we may die suddenly. So the causes, particularly in our place also here, atherosclerosis is the commonest one. Increase due to the pressure, the blood clot may be rupture, suddenly block the lumen. This is called acute coronary syndrome, what the previous our speaker had mentioned. So when this suddenly block, that is called acute coronary syndrome. No blood supply to the biopsy tissue, this is a myocardium, dead or myocardium. This one, this infarction, this is dead. So this is a common, everybody starting chest pain. This is the lumen. When it is ruptured, otherwise suddenly it is ruptured. Then acute coronary syndrome. This is ECG. Everybody knows what is ECG, but I want to mention that the second one, this one, just see, the legs are rising up. Makong says that pro do it type. Iski infarction, when I like the music, starting the music. Makong tangle says that pro. One, I do it time. He's giving a hand. I don't know. We should see at least some basic knowledge when we are looking about ECG, not only the heart rate, but let's see the pattern, see the two phases. Heart attack is more common in early morning, may occur after a heavy meal full of fat, may occur after a sudden anger or excessive soreness, or may occur during the process of angiography or angioplasty. Particularly in our place, we have come across many heart patients after taking full fatty diet, particularly luhomba sakoba mangani subun cha ronga thoma sen cha yum laga mayung kakapada to salaga sibase yam toy thinare hoi Manipur. This is why I am just reporting this. It may not be given in the books, but it is come across to our finding or clinical practice. Another one is cardiologist doing angioplasty. When the thrombosis is there by the coronary, it may rupture. So many patients die on the table when the patient is brought for angioplasty because of this rupture. When the patient is taking rest, it is not, but due to the catheter. Warning signal to heart attack, everybody knows. The previous diagram, chest pain, discomfort, dizziness, light headache, palpitation, irregular beats, excessive fear. But when you are more than 40 years, any chest pain, any palpitations, any dizziness, or any panting attacks, please don't neglect. That's why, if you are neglecting, you will get the punishment. So chest pain might radiate towards the back, left shoulder, left arm, or jaw associated with shortness of breath and profuse sweating. One more finding is that not only the left side of the chest, pain on the right side also associated with the heart disease. We have come across, may not be given in the books, but I have not seen, but pain on the right side, 40 years old, coming. And after taking ECG, found that patient having ischemic attacks. Computer is long, you are the cannon tower. Hang tower. Matang. Yeah. So, what are the factors? Let us divide in two groups. Risk factors, advanced age. Why? What is the problem? Advanced age, it may have arterial stiffness, atherosclerosis, hypertension, dyslipidemia, inflammation, glycolysis, hemoglobin, diabetes. More in male, postmenopause impairment in females are common. Hypertension, risk factor. Why? For every 20 millimeter of mercury increase the systolic blood pressure, or 10 millimeter of diastolic, increasing diastolic blood pressure, have the problem of this heart attack. Thickening of the medial walls, most only thickening of the medial walls, blood vessels due to the remodeling, endothelial dysfunctions. So, when the patient is having hypertension, we should know the mechanism of these things, and particularly endothelial dysfunctions, increased platelet aggregations, increased homocysteine and fibrinogen. All these are responsible for this diabetes. Again, independent risk factor, diabetes. Many causes there, but it is an independent risk factor, particularly endothelial dysfunction, inflammation, heterogeneous, dyslipidemia, deposition of the calcium, edema, heart stimulus of vessels, hypercholesterolemia, atherogenic, premature, atherosclerosis, pro-inflammatory properties, plaque formations, plaque instability, smoking. In spite of repeated requests, patients don't smoke, but smoking, the causes of endothelial dysfunctions, obesity, particularly this is also another independent risk factor. Waist to hip ratio more than 0.99, hypertension, patient may diabetes, patient may dyslipidemia. Secondary lifestyle, increased atherogenic tendency, diabetes, hypertension, all these responsible mechanisms. Family history, genetic, independent risk factor, infections, particularly viral and bacterial, chlamydia, pneumonia infections, endothelial dysfunctions, aggravations of plaque activity, atheromatous plaque destabilizations by activations of inflammatory cells. Okay. Another new risk factors. Here I want to mention lipoprotein, lipoprotein B, and serum fibrinogen. Out of this, lipoprotein is independent risk factors, and the serum fibrinogen also independent risk factors. Particularly about the lipoprotein, to test whether it is increased or not, it is also costly material. Genetically risk factor, 10 times more atherogenic than low density lipoproteins, produces RA atherosclerosis and thrombosis, more common in Indians. So this is lipoprotein is an independent risk factor, more common in Indians, whereas apolipoprotein B is again in combination with low levels of HDL and hypertriglyceridemia, 3 times incidence of coronary disease more. Serum fibrinogen, these are another independent risk factors. So diabetes, lipoprotein, and serum fibrinogens, all these are independent risk factors. Hyperhomocysteinemia, this is another independent risk factor. Not related with any other factor, but if it is more, patient may have chances of heart attack. Sulfur-containing amino acid, deleterious effects on individual functions, pro-thrombotic, pro-oxidant, and higher in Indians and mitogenic effects. Plasminogen activity inhibitor associated with hypertriglyceridemia and hyperinsulinemia, thrombosis by impairing fibrinolysis. C-reactive proteins should be less than 1 milligram per liter, best characterized by inflammatory biomarkers indicating chronic infections and inflammations. Hyperinsulinemia means diabetes, insulin resistance syndrome, independent risk factors. More on Asian Indians, marker of atherogenic called syndrome X, high triglyceride, low HDL, obesity, and glucose intolerance.
Excuse me, sir. Excuse me, Tama. You have 2 more minutes, please.
Unavoidable risk factor: age, sex, male, family history, diabetes, increased serum fibrinogen, increased lipoprotein A, hyperhomocysteine and hyperinsulinemia. Avoidable risk factors are cigarette smoking, high BP, obesity, lack of exercise, and stress. These are avoidable risk factors. Other factors are unavoidable risk factors, I want to say. So, heart attack can be prevented by taking care in the avoidable risk factors. But may not be possible in case of age, sex, family history, diabetes, hyperinsulinemia, increased lipoprotein A, hyperhomocysteine, and increased serum fibrinogens. Thank you.
Thank you, Tom. Your very precise and comprehensive deliberation, and you have saved 1 more minute. Thank you. And due to paucity of time, we won't have any question in the answer session. And I'm very thankful to the organizer for giving me sharing session with my esteemed teacher. Thank you, sir. Thank you.
We have had a very useful lectures. I thank the speakers for their good performance, and now we declare the session closed.
Thank you, speakers and chairpersons. To felicitate the speakers, I would like to call the chairperson. Please proceed towards the right side of the stage. And to proceed the chairpersons, I would like to call on Dr. S. Jugendro Singh. And we will proceed to the next CME, for which for which I would like to call on the following chairpersons on the stage. Dr. Sinam Rajendra Singh, former head of Department of Urology, RIMS Imphal, and Dr. W. Jatiswar Singh, former head of Department of Radio Diagnosis, RIMS Imphal.
Anyway, while the distribution of the certificate taking place, let us have the post-lunch session. It is very much behind the schedule. We are going to have very, very interesting 2 topics. One is sports medicine. Very, very few institutes in the country run this particular course. And Professor Joy is going to talk on a topic return to sports after sports injury. Professor Joy is the head of Department of sports medicine. Is he not? Yeah. Yes, sends to sports medicine. Yes, please. Without a hungry man is an angry man. All are angry. So please go ahead.
My teachers, my respected teachers.
We'll be reminding you 2 minutes before.
And friends. So, sports injury, it is very challenging to the careers of the elite sports persons. And any hero can become zero because of injury. But for many, it is not a roadblock because they come back with standard practices. So we also have best athletes, especially in the second row, Bala, Kunjarani, Medicom, they all suffer from severe knee problems. They were all operated. And something is true, like success is not in never falling, but rising every time you fall. That is important for them. And they are brought back to the field, to the track, because of their strong willpowers and undying motivations. So sports injury is a part of the game. And commonest ones we come across are ligament injuries, sprain, and strains. So my talk is all about from curses to running shoes, and starting from the injury, standard care, and followed by the very good rehab practices and coming back to the sports. So this is about, that is what is being announced, return to the sports after injury. When we talk about sports injury is injury during competition or training or by any exercising person. It comes under sports injury now. So there are not 3, but there are 4 elements now: return to training, return to participation, return to sports, and return to performance. This is a continuum process. So Sir Rajan used to tell us, you in the medical colleges, in the RIMS, he said, you flourish or perish. But in sports, it is perform or perish. So like, sports is the clear example of the, the survival of the fittest. Therefore, since we are stressed to the maximum, chances of injury are very high. So once you see how much range of the mobility, how much strength, how much stability you need while performing sports activity, we are stretching to little limits. Therefore, sports injury cannot be, it will remain a part of the game. So you all may know that Bala, she was in Rangers FC. You can see her physique. Her physique was as good as European team members. And she also had very bad knee injury, and she was operated. But she came back because of the undying motivation, as I have mentioned. So let me start from this. There are 2 there are components, physical fitness, and understanding sporting fitness is very, very important. In India, what we have is sports-specific fitness, but we don't have a basic fitness. The basic fitness is lacking, but we have sports-specific fitness. So unless our foundation is strong, we cannot build buildings, multi-story building. That is one of the problems we have in India. So when we talk about general fitness, it consists of the flexibility, strength, endurance, coordination. And when I talk of the sports-specific fitness, because like flexibility of gymnasts and its flexibility of weightlifter cannot be same. Strength, the weightlifters will have different from the gymnasts. Strength also, endurance, a runner should have more strength, more endurance than the weightlifters. So these are game specific. So we have both basic and the game specific fitness. So injury, any injury, ligament injury, any problem, injury is, it causes joint malalignment and leading to the faulty biomechanics, and most important is faulty compression signal. Because of that, there is proprioceptive deficit. This is one of the reasons, even when injury is healed, but this is not recovered. So many of the instances, because of lack of practice on the proprioception, many could not come to the original level. So please remember, proprioception is one of the most important components of the training. So there are many literature which says like after injury there is joint position and the motion sense is lost. So this must be regained before resuming to the practice. So we talk about immobility in general cases, but in sports we talk about active rest and local rest only. So because there are many other issues coming up, this must be avoided. Rest must be avoided. So whenever we treat any patient, any tissue, wherever it takes time to heal, whenever we deal with such a patient, we must respect the healing time. We should not try to hasten this process. Healing is a natural process, it should continue. 2 things we should understand. We have different body segments. These body segments are combined and coordinated in a kinetic chain. A segment doesn't move in isolation. Our body movement is in a kinetic form, number 1. Number 2 is the speed and strength the person exhibited, it is generated from the ground reaction force. The speed strength comes from the ground reaction force. So I can have an example. If you want to have a very fast serving of the lawn tennis, we don't have to strengthen the upper limb too much, because though service is done by the upper limb. So we have to strengthen the lower part of the body to generate very good ground reaction force. So few more things. we were giving more emphasis on strengthening exercises, but whatever strengthening exercise we do is without any velocity. But we don't do any activity at that velocity. We are throwing, we are boxing at a very fast speed. So there is one particular strengthening instrument that is called isokinetic, exokinetic machine, can strengthen the person at that particular speed. So we also have this instrument. Another is, now we are all considering about the concentric, shortening contraction of the muscles. Now, in sports medicine, we are giving more concentration on the eccentric, lengthening, muscle strengthening, we are giving more emphasis. It is involved in all the sudden jerks, sudden stoppage, everything. The more important than the shortening contractions. So, as I have mentioned, proprioception is not to be forgotten. Because of this, many could not return to the sports proper. So, at the end, the finishing touch is so-called plyometric, where this is inclusive of the flexibility, about the concentric, eccentric exercises, and in addition, there is explosiveness is added. This is one additional thing. So, okay, it's not coming. So, don't look, on sports injury, don't look at the injury only. We have to look at the psychological, at the physiological, at the social, so many other factors we have to look at. So, whenever we do rehabilitation just like other people, we stop at rehabilitation. But in case of the return to sports for a sports person, there is a stage called pre-rehabilitation. That is, all the sports-specific trainings are done in this. I will be showing that. So, in the rehabilitation program, there are 4 stages. In every stages, there are goals. There are, in the first stage, second stage, what are the physical therapy to be done? What are the exercise program? And please remember, the sports-related activities are started from the day one. We don't wait for the tissue to heal. That is important for us. So this is in short what we do in rehabilitation. We treat and we try to get range, strength, endurance, coordination, and sports-specific skills. Psychological fitness, I'm coming to this. This is very, very important, and return to sports. So there are 2 important written protocol. One is decision-based return to participation model. Another is bio-psycho-functional model. I follow this in our department. I'll come to that. Then another one I want to convey. So there is no consensus that a particular person, a particular injury can return at this time. It depends on the severity of the injury and the type of the injury. So there is no consensus of the timing, though we respect the tissue healing time. So this is again important. There are few sportsman specialists or other specialists who depend mostly on imaging, like MRI, ultrasound. But the consensus is that don't wait for all the signal alteration 100% coming to normal. If 70% signal alteration is done, then go ahead with the training. But it is not mandatory to have MRI to resume to the sports practices. So this is very important. I said earlier, psychological factors are likely to be the important determinant of successful return to sports. This is psychological factor, it depends. I'm concluding with that also. This is very, very important that we are lacking in that. And one of the reasons why people do not come back very early is because of fear. So when to return? This is important for everybody. Every one of us mostly are primary care physicians. Please remember this. We must respect the healing time. Second is pain-free, full range of movement, no persistent swelling, adequate strength and endurance. We want at least 90% of the strength and endurance to return before the resuming of the practices. And good flexibility. Flexibility, when we talk about flexibility, we are talking about the stretchability of the muscles. When we are talking about range, we are talking about joint. Then proprioception and balance must be achieved. The cardiovascular fitness must be achieved. There must be no persistent biomechanical abnormality. It will be examined by the coaches, the trainer. The sports-specific skills are regained because they are going to return to the sports. And the athlete, most important, psychologically ready. His or she is ready. And the coach also is satisfied with the training form. So I talk about pre-rehabilitation program. This is some of the programs. Okay, this is what we do before coming to the football proper. Okay, this is some of the, so line drills, then hoppings, and figure of 8, pro agility, shuttle test. These are few sports-specific training related to soccer we do. So after that only they can do that, then we allow them to join training. So in short, the functional program is like this. Okay, this is a combination of so many things. Like we start with the running, sprinting, and we jump and heading the ball. Then we run around the cones, and then backwards, pick up the soccer, and dribble around the cones. So something like that. There is a program before they come to sports specific, like this is for soccer. So when you said that a person is completely rehabilitated, we say a person is completely rehabilitated when this injured person has completed one full season of sports successfully following the injury. Only when we say he is fully recovered and rehabilitated. So who answer that who is fit to return? So according to this editorial, the responsibility is given to the sports person. Let him decide whether he is fit to return. If he says, I am ready, let him return. But like as doctors, as psychologists, we should keep all other things, but the final decision maker is the sports person, not any other person. So hopefully I try to convey some of the things, and this is mostly, again, this is not for the specialists, it is for the primary care physicians. Thank you very much.
You are right in time, in the dot, even 1 minute ahead of it. Anyway, as he has shaved his time, allotted time, questions are invited. No questions. Very interesting sports. Yes, please, come. Introduce yourself.
He doesn't need any introduction.
Some may not know. He is another aquarium.
My question is sort of general. When we talk about the rehabilitation and return to sports, as you have already pointed out, is a multidisciplinary approach. We need many people out there. So I just want to ask this question that, do we have a complete team now? This is on the backdrop that an MD in physiology, per se, he cannot be a specialist in sports physiology. MD in psychiatry cannot be a sports psychologist just like that. So we need training for that specifically. So in this backdrop, do we have a complete team now?
Yes. So there are teams, there are team members. Okay, problem in India is we don't have the complete team members. But like, it is ideal to have the team members because any rehab program is a combined and a concerted effort of the team members. But when we don't have, in some of the instances, in some of the, like finance, the poor areas like Manipur, we may have to take up many of the instances. But I am happy to inform you that we have a post of the sports physiologist in our department that is yet to be appointed. We are presently using sports psychologists from the National Sports University to train our students. We are also utilizing the Sports Authority of India, the sports physiology lab there also for our students at this moment of time. Because when we are developing, and in due course of time, probably we have been in the project. Once project is converted to the full-fledged department, probably will have all infrastructures and manpower with us. That time, there will be a reality on that.
Anyway, Joy, you have used a term, no biomechanical abnormality. What do you understand? What do you mean by that?
Okay. So like when we examine one of the joint, then we see two things, what is called kinetic and kinematics. Another is how the joint moves and how the muscles that is moving the joint is behaving. These two we see. It's like Sir Kala mentioned about the limping ECG, something like that. If the person is limping, we know that the joint is not moving in a particular direction and the muscles, those are supposed to act, it is not acting at a particular moment. So we are seeing kinetic and kinematics in biomechanical examination.
Thank you. Thank you.
Thank you, Professor Ege Joy. I think it is very new concept, and I don't know what questions we are going to ask you. They are very new concept. No? Thank you so much. Nice presentation.
We'll go to the next speaker, that is our Professor Aish Manihar. He was our professor in our Regional Institute of Medical Sciences. He went to Mizoram and he was head of department of surgery as well as the dean of the institute, Joram Institute of Medical Sciences. He is going to deliver surgery in old age. You have to define old age also. I am not old. So, on here. So anyway, welcome home, and please start your talk. Yeah, you can use this mic. It's ready.
So, with the permission of the, where's the mic? This can be done from here. No?
Maniar, 15 minutes.
Okay.
Okay.
With the permission of the chair, let me just go to the topic. Where do you go? How it goes? PPT, how? Okay. The topic of the my talk is surgery in old age, because as the life expectation increases, because we are going to face more and more old people undergoing surgery, and you know that women always outlive men. So in surgery, because people aging more than 80, 85 years, we are going to encounter more and more of such people undergoing major surgery. This is a really important topic, especially in the West, because women always outlive men. That means, we'll be encountering more and more older women, like 80, 85 years, undergoing major surgery. There's a big problem in the West. And it happened even in, because in India, it's a little bit better because we have a different system, we've got a family and all that. But when you go to the big cities like Delhi, the things are changing slowly and slowly because, the first child may be working as a software engineer in Bangalore, where the second may be an administrative officer working in United States and all that. So the poor parents will be left alone with some helpers and all that. This is the real problem facing surgery in the old age. This is why this is the subject. Now, emergency surgery, as we all know, elderly carries a mortality rate of 3-4 times than an elective surgery. And with increasing life expectancy, because we are going to expect more and more people living longer as we go on. So with increasing life expectancy, a dramatic increase is expected in the number of old patients that will require various forms of intervention in the near future. But what exactly is an old man, old age? When we go according to Collins Dictionary, old age is the quality or the state of being old and near the end of one's life. This refers to the ages nearing or surpassing the life expectation of human beings and is thus the end of human life cycle. It also can be taken as a period of years towards the end of your life. WHO also defines old age as 60 years or over. According to AMDS project in Africa, as low as 50 to 55 years can be used as an old age. In the West, 60 to 65 years is usually taken as old age. In UK, it's about 65 years, and in the US, 67 years. But how do you know that we have grown old? One day you go and just look at the mirror, and you think that the person that you are looking is your father. That is a time we should understand that you have grown old. But what is a life expectation? Because it's very important. The life expectation given in 2017 is for North America, for men it is about 76.4 years, for women about 61.2 years. Monaco, which has got the highest life expectancy, is about 89.52. Chad, a small country in South Africa, a small country in Africa, is only 49.8 years. But the life expectancy is projected in 2050 is about, for men, 83.86 years, and for women, 89.94. But what about the life expectancy in India? For male, 67.6 years, and for women about 70.1 years, and average is about 68.8. But in 1947, the average lifespan of an Indian was only 31 years. Forget about the 1947, when we were small. People about 40, 50 is considered to be very old. And then those days, people dying of cancer was unheard for. Unheard for, it is there, but we don't hear it. Why? Because most of the people do not live long enough to suffer from cancer. Because cancer is essentially a disease of the old, even though we have got some younger people or cancer in the patient. So it is usually that is the reason, one of the reasons why we don't find. People die of tuberculosis, and people died with smallpox and all that. Jawaharlal Nehru's wife died, when because there was no drugs, and then she died in tuberculosis. Because there was no drug, change of climate was considered to be a treatment, national treatment. And the Imani sisters, you know that all three very famous sisters, they all died at the age of 30, around 30, 31, 29, like that. Three very eminent sisters, because they all suffer from tuberculosis. It's a dreaded disease. Then we had smallpox and all that. In 2005, average lifespan expected was 64 years, and more than 50% of the Indians are below the age of 25, and more than 65% of Indians are below the age of 34. That is why our Prime Minister Modi said, we Indians have got a workforce. Quite contrast to the Americans, who has got, all average around 80, 85, they are not working people, but here in India we have got 25, 35 years, most of them are working. That is why India goes up. This is why, one of the reasons why China goes down, because China, they observe one child normal, and then because of this, they continue for about 15, 20 years. Nowadays, many of the couples, because they went without child, any child. Now, many of the couples are without children, and they are barren type, So in China, they want to increase the population. That is one of the reasons why India overtakes them. And then they give, to the school, college going students leave, so that, people of both sexes can mix with them, That is the trouble they are having. Any guess about this? Yes, this is the Collian. He is the child star of Home Alone. By 13, he has become so famous. Then he got indulged in, drugs, alcohol, and a lot of other vices. This is what you look, the other on the right side, this is what he looked at the age of 23. Look at this, our own Indian beauty. She is the Maharani Gayatri Devi of Rajasthan, princess of Kuch Bihar. She was listed as one of the most beautiful women in the world by Vogue. She was put at number 6 next to Grace Kelly of Monaco. This is what she looks at on the right side. This is what she looks at the age of 70. I had an opportunity to meet her, to see her when she came to Polo Ground in connection with, polo, something to do with the princess, This is what so gracefully ages. But what are the physiological changes which are taking? Because we must know the physiological changes which are taking place in an old age, just to know that what are the other changes. Aging affects all physiological processes. An irreversible change in function in most organs occur by the third or fourth decade of life. But the rapidity of the decline in function varies with organ system, but is relatively constant within a given system. But the rate of changing is the same for a 45-year-old as it is for an 85-year-old. Only difference is when you reach 85 years old, then you started getting accumulating age-related other problems, no? That is the problem. But one important thing is to be remembered, because we should know the normal attrition to be made between the normal attrition of function occurring in all persons with advancing age, and another on the other side it is the loss of function that marks the onset of pathological changes from one or more diseases encountered usually during the older age group. Because the failure to recognize this difference will lead to progressive disability from treatable disease. Then let us see what are the common changes which are taken, because I'm not taking up everything. See, in cardiovascular system, the heart, the cardiac output increases linearly after the third decade at the rate of about 1% per year in a normal subject. The cardiac output of an 85-year-old is subject to about half that of a 20-year-old. So at the age of 40, however healthy you are, you cannot expect to sprint 100 meters below 10 seconds in an Olympic. It's impossible, because your organs, your system simply does not just allow it. Then the senescent cardiac muscle has a decreased ionotropic response. These are some of the response that body is going to get, to the catecholamines, both endogenous and exogenous. The associated increase in diastolic and systolic myocardial stiffness is due to the myocardial interstitial fibrosis. There has been a progressive stiffness of arteries. This will lead to increase afterload to the heart. Moreover, amyloid deposition in the myocardium, predominantly in atria, ventricles, and pulmonary vessels also takes place. This will lead to congestive cardiac failure, often with conductive defect. Hypertension, because these are the common things that, and what you get, as you grow old. The progressive increase in blood pressure in the first decade is taken to be quite normal, but elevation is more pronounced in the systolic than diastolic. Why I say diastolic? Because after about 60 or 70, diastolic may remain, pulled down, but while the systolic may go up. The thickening of the walls of the arteries, accumulation of calcium, and accumulation of elastic fibers progressively occur with aging. On the other hand, the myocardial infarction, coronary artery disease dramatically increase with increasing age. But some of the common conditions like hypertension, obesity, cigarette smoking, etc., can be prevented or controlled by proper treatment, etc. What about in the respiratory system? It's the same thing. The respiratory, in lung volume, there has been a linear decrease of vital capacity when you reach by about 26 ml per year in males, and 22 ml per year in women starting at the age of 20. This is to be noted, because you cannot sprint, I tell you, 100 meters, just like people like 25 years old. Total lung capacity remains constant on the other hand, but residual volume, the lung increases with age. So residual volume is to total lung capacity about 20% at the age of 20, which will be 35% at the age when you reach 60 years of old. Gas exchange. Alveolar oxygen tension remains constant with age. The arterial pressure shows progressive decrease. Elastic coil of lung decreases with age. And then various other conditions like, then they lead to airway collapse. And then 30% of the...
Manyar, you have got 2 more minutes.
Only 2 more minutes.
2 minutes, no?
Yes.
5 minutes. Okay, these can increase in with incidence pneumonia. Respiratory system.
I think please come to the surgical part. Surgical, your...
Lung volume also, again, there is changes taking place in lung volume. Residual lung volume is about reduced to 25% in 60 years of old. And respiratory system, lung volume, again, you know, everything, lung capacity, everything is reduced in old age. 2 minutes, no? I'll finish it. Hypertension, again, as we all know, hypertension, there will be progressive change in hypertension, and then there will be, because of thickening of the wall, the changes in the arteries, etc. Hypertension, obesity, these secret problems, these will be there. The senescent cardiac muscle decreased hypertrophic response, and response to catecholamine will be less. Associated increase in the diastolic and systolic pressure will be there. Then over and above this, amyloid deposition and other things also will take place. Heart, everybody knows, you know, majority of the problem will be facing in the heart. So cardiac output in a 80 years old subject is about that of a 20 years old. But distinctions is to be made between the normal attrition of function occurring in all persons with advancing age and the loss of function that marks the onset of pathological changes from one or more diseases encountered in the older brain. Then cardiac muscle, you know, these are the various cardiac changes which is taking place in all age group. And the hypertension, as you know that, you know, this is another problem that you get in the myocardial infarction is very important. Hypertension, both these are, can be, respiratory system, again, lung volume will be decreased and total capacity and all these things are there. And then hypertension is another one.
It is repeating. Please come to the surgery part.
Oh.
You have gone, you have pushed the button wrongly.
I think,
You come to the surgical part. 1 minute. Or conclusion mein.
It is going up, I think. There's something wrong. Skin, musculoskeletal system, everything, there will be change. And just I'll just sum it. Old age is not a disease. This is something which, you know, one has to encounter in their lifetime. Old age is the uninvited guest who will surely knock at your door one day, and one should be prepared to welcome it. One must understand the physiological changes taking place in the old age. But the distinction must be made between the normal physiological and then the changes which is taking place because of the old age. And one important thing is, children are not just little aged because their physiology, everything is different. And the elderly are also not just young adult. Elderly has got their own physiological. And old age must be enjoyed and should not be lamented, because this is one you are bound to get it. Summary, old age is not a disease. It is a nature's gift to all the living beings. Elderly patient represents a unique surgical challenge due to the complexity of the comorbid condition and physiological changes. The hallmark of this change is the decrease in the functional reserve and inability of the surgeon, of the system to cope with the challenge like surgical stress. But with improved technologies, expanded criteria of the surgical intervention, awareness of the special needs of these functions is required. Multidisciplinary approach, including nurses, dietitian, even the public is required. Thank you very much. Thank you.
Thank you, Manihar.
Thank you.
On behalf of everybody, I will ask one question. I won't allow others to ask question because why the male are dying earlier than female?
What?
In your slide, repeatedly you have shown men die about 5 years earlier than the female. Why?
I don't understand.
No. In your slide, you have shown we male are dying earlier than ladies or female.
No.
Why? Explain.
No, there's no, this is the statistical finding which is present everywhere. Because you see, you go to anything, because they do a lot of research, but everywhere, every country, including India, women outlive men. This is a finding everywhere.
Question is why? Why? Question is why?
Because
I know it is, we are dying earlier than ladies, so.
Because there's no why. Because
it's a fact. No, it's a fact. As the speaker said, yeah, answer. One lady is coming up.
Maybe there are a lot of other things are there, physiological condition, and then...
Very wonderful question, sir. I think we are dying because of the pressure being given by the ladies to the men, to the guys. So we are constantly pressurized by the ladies, so we die earlier.
And then another thing is the natural.
So ladies, please take care of your husband.
God given, this is even including India, I know it is.
No, I agree. All over the globe, male are dying earlier.
Sir, will you allow me one question, sir? This clinical and practical question. Will you allow me one question?
Okay,
yeah.
Agreed.
I am getting many patients who are old age patients, and the doctors have been telling them that you are too old to get a gallbladder operated. You don't operate, and they come to me, and the oldest person who was operated by me for gallbladder was 94 years of age. So is there an age limit where you can say that you are too old to get any operation done? Don't do operation. Is there any age limit like that?
Yes, this is what I wanted to answer, because there is no age limit for anybody that he's too old. I'll give you an example of my father. This I could have started early. My father died at the age of 100. And then, he has got a, close friend, who has become a famous astrologer. He had predicted that, he will have some catastrophe at the age of 90. At 90, he suffered this thing, and then he underwent prosthetic surgery here. And then he lived for 10 days. During that 10 days, then he died at the age of 100. In that 10 days, he wrote 2 books. And what he did is, what he couldn't do in his 90 years of active life, he did it in those 10 years. This is why I want to stress there's no age which is too old for surgery. Because we have got a lot of others in geriatric surgery, lot of other super specialists. You consult with them, and then please carry this message. Nobody is too old to undergo any surgery. Please consult them and please do it. Otherwise, if you don't do in this thing, they will die of the disease.
No, in this, the performance status of that, you have to individualize. You have to individualize, don't go by age. Chronological age different. So, I am now, today I am entering 73. But if you do Tira Ura 37, I am, you understand, I am climbing the Cherauxing. So, what I mean is that suppose if my ejection fraction is 20 or Takala has come up, so you don't subject, you will be in thick soup, not in thin soup, thick soup. So that is what I will tell. Takala.
One thing, because this is one of the reasons that I present this, because there is no age is too old to undergo any surgery. You consult with geriatric surgeons and so many other people are there.
I want to give one suggestion to the junior doctors. When this surgery means for different categories, okay? General surgery, respiratory, cardiothoracic, orthopedics. But I want to mention, give the suggestion to you that, to the junior doctors, what are the precautions that to be taken before surgery and after surgery? Suppose if you want to operate in an old age patient, okay? So,
precaution has to be
taken. Shortcut. Before the surgery, what precaution to be taken? After surgery, what precaution to be taken?
Thank you, Takala. Thank you, Takala. Thank you, everyone.
And you take opinion from all the person concerned. The geriatric surgeon is there.
Thank you, the organizing committee, for giving us the chance to share this.
No age is too old for surgery. What I wanted to say is no age is too old for surgery, and we have to undergo for that. Thank you.
Thank you very much, sir. On the lighter side, I was just thinking with the title given by Sir Manihar, Surgery in Old Age. So I am touching 50, I was just thinking the other side. As a surgeon who is becoming older, how do you do surgery? So I thought the topic was on that side.
Thank you, everyone. I hope it was a very meaningful discussion. To felicitate the speakers, I would like to call on the chairpersons to felicitate the speakers, and to felicitate the chairpersons, Dr. Sinam Rajendra and Dr. W. Jatishwar Singh. I would like to call on Professor R.K. Lenin Singh, sir, to felicitate the chairpersons. Yes, sir.
বলো বস হ্যাঁ চলে যাচ্ছি